So in this PowerPoint, you're going to be learning about diseases of platelets. And when you think of platelets, anytime you see a question asking about clotting, something involving clotting factor, okay, you're gonna want to be making sure you're thinking about what is exactly going on. Okay, what factor would be affected? So if it's a leukocyte, white blood cells, you're likely experiencing infection at higher rates, right? If the condition is involving fatigue or anything that would lead you to saying oxygen transport is the cause of, or is the result of the disease, okay, then erythrocytes would be the option. And for platelets, anything about clotting, clotting factor. Okay, so the normal cells and our normal levels of these platelets in our body are between 150 to 350 cells per milliliter. They have some terminology that needs to go with them. So thrombocytosis, okay, is increased levels of platelets, right? Whereas thrombocytopenia is lower levels of platelets. And so this is a particularly important set of disease states here because this is going to affect the coagulation, blood clotting. So capillaries are leaky. They can start to leak in random parts of the body, and they cause this leaking of blood out of the circulatory system to cause this. Okay. And so for the functions, the diseases of platelets, we're going to focus on hemophilia A, von Willebrand syndrome, and then disseminated intravascular clotting, and then idiopathic thrombocytopenic purpura. And then that's going to round this audio lecture out. So hemophilia A is the first platelet disorder that we're going to talk about. Hemophilia A is an X-linked disorder. It's passed down through the X chromosome. So men get it. It's recessive allele, and so you only need one copy, or so you need two copies if it's a normal autosomal pair. But since it's X-linked, if it's recessive, then it always expresses itself in males. Okay, or has a 50% chance. So we see that in this case, the sex-linked genes. This is associated with sex-linked genes like Fragile X syndrome. They're both pretty severe disease states to get diagnosed with. Okay. This hemophilia A results in a improperly put together factor 8, and factor 8 is a part of the clotting cascade. Okay. And so the severity of the disorder can vary quite tremendously, and so sometimes we can see really severe cases, and other times it can be relatively minor, but it's always a concern for something that would necessitate clotting, blood clotting, or coagulation. How is this going to perform? So they're underproducing factor 8, and so they really would have a decreased ability to clot blood. Okay. Bleeding is always going to be the main manifestation that we see, and we can see certain indications of internal bleeding, like bruising, okay, or petechial spots. So if you look at the image right here to the right, you can see the petechial spots in this little circle. And so petechial spots are just small little places where blood has broken through the capillary, okay, and is starting to leak into small little areas like that. And so it's not very broad, but you'll usually see a number of them clustered together. Okay. So in helping us diagnose hemophilia A, I'm going to be looking at some particular things, so clotting studies and serum factor 8 levels of a few. So the clotting studies, I'm going to be looking at things like time to finish clots, coagulation, and then formation of some particular components involved in the clotting cascade. Okay. So specifically, I'm looking for prolonged prothromboplastin and then activated partial prothromboplastin factors. I'm going to be looking for that increase in time in coagulation to actually occur. So the next strategies that we have can include treatment, obviously. So in this treatment, I could always consider something like clotting factor transfusions. But really, what the idea here is to stop really doing whatever is required, and if it that is required to induce the blood loss. So trying to stop that. If you have an individual who has this hemophilia A, which is a decrease in clotting factor 8, we can do acute injections on the site of some individuals, right, with mild cases. More severe cases for hemophilia A are going to require probably preventative medicine. One of the good things here, a nice drug that we can use to increase synthesis of factor 7 or factor 8, is this antagonist called desmopressin. This blocks antidiuretic hormones action, so vasopressin. Well, as it blocks those ADH receptors, or antidiuretic hormone receptors, or vasopressin as it's known, then it actually produces factors 8 for release into circulation. So we can actually increase the amount of factor 7, which was limiting before, and so then we could begin to clot normally. Now again, the precautionary advice is kind of what you're going to use for treatment by not even getting the problem. The next condition that we're going to be introducing is von Willebrand's disease. This is von Willebrand's disease. Sorry. This is a really common bleeding disorder, and so we don't really need to pay too much attention to this stuff. But what we do need to pay attention to is this. Okay, so these guys, von Willebrand's disease increases platelet adhesion in a normal activated platelet, and so here you see von Willebrand syndrome in the coiled form, and then it gets around platelets, and von Willebrand syndrome is activated at that point, and it straightens out. And as it straightens out, it provides a lot more contact areas for these little epitopes on the platelets. Okay? And so this is a part of blood clotting, right? So forming the platelet plug. Well, we have to have something there, and so it's von Willebrand factor that actually suggests that mediates this relationship. So we have 3 types of von Willebrand's disease. Type 1. This is going to be the most common type, 70 to 80%. It follows autosomal dominant inheritance, and all it is you get reduced von Willebrand's factor. Okay? So if you decrease your von Willebrand factor, you're going to decrease your ability to form that platelet plug, and that's really what you need to get all this started. And so type 1 can oftentimes go undiagnosed, but in an individual where it causes this bleeding event, it can cause a tremendous amount of trauma. Okay, so this type 2 version of von Willebrand disease can be a autosomal dominant or recessive trait. It only makes up about 10 to 15% of all cases. It has multiple subtypes, so it is kind of tricky, these multiple subtypes. And then, so this von Willebrand's factor actually is shorter now in length, and it breaks down easier. So now it doesn't actually, so the platelet plug will form, but it might not be very strong, right? So it might, if it's abrased at all, it might just open back up. Type 3, this is going to be your genetic type, right? So this type follows an autosomal recessive kind of inheritance pattern. There's no measurable von Willebrand factor or factor VIII. Okay. And so now we can't generate this blood clot because now we're missing two things. Okay. And so you can see severe bleeding problems as a result of this. So then there's the acquired type, and this is the other version of, in addition to type 3. So in the acquired type, this can occur due concurrent with the formation of a Wilms tumor, which is right over here. So this is a Wilms tumor. This is going to be a renal cancer, malignant growth. Okay. You can see it associated with some autoimmune conditions, and so congenital heart disease, hypothyroidism, and so we see it also associated with these other disorders. Okay, so to diagnose von Willebrand syndrome, you're going to do a bleed study. So bleed time, thrombin presence in the blood, factor VIII levels, and so if you remember that we not only have the von Willebrand factor affected, but we also have factor VIII levels that are important in the cascade as well. Now, to treat von Willebrand syndrome, usually the cases go unnoticed, but sometimes they do. And so the first approach that we're going to use is cryoprecipitate infusions. And this cryoprecipitate infusions it's infusing proteins essentially that are procoagulant proteins. Okay. Administration of desmopressin, which we saw desmopressin helped with factor VII production or factor VIII production that we saw in hemophilia. Okay. And then anything to limit the amount of bleeding, and then measures obviously would be needed to control bleeding. Okay. So disseminated intravascular coagulation. So what is it? Okay. It's a life-threatening complication with many conditions, but it pretty much results in blood clots forming throughout your body, and then you've depleted your clotting factor library pretty much, and so now you involuntarily form clots in your circulatory system, but then you can't stop bleeding as a result. So this is a pretty severe condition. And so the results are generally from an inappropriate immune response, so an autoimmune disorder. Okay. We see that, again, widespread coagulation is present, so that's where disseminated comes from, so widespread. Okay. And then intravascular coagulation because it's occurring in the blood vessels. It's followed by massive bleeding generally, just because of what I said. So they are wiping out the clotting factors that you have here. And so some problems can be here is that your blood pressure would drop too much in the case that you get this massive bleeding event, right? So if blood pressure drops through the basement, you can't maintain blood flow to your head anymore, right? So you end up passing out as a protective function. Okay. Since this is affecting blood flow to other organs is going to be affected. So this could be a potentially really bad scenario if it went unchecked or unnoticed at any point. So how would you diagnose disseminated intravascular clotting or coagulation? Do a CBC and then a bleeding study. Okay. So you're going to be looking for any extended amount of time in bleeding, but at that point you might want to monitor the blood here for clotting factors as well. So look at each individual one of those and see, are they all depressed? Is it just one? What is it? Right. So the treatment for disseminated intravascular coagulation is identify, first of all, the cause, right? So the cause is going to be the first problem, and then treat that. Replace any of the clotting factor components that you can. Okay, so administering artificial clotting factors can help it. Okay. um, and then prevent unnecessary coagulation. So prevent that initial coagulation from happening in the first place. Okay, so now we have another condition. This is called idiopathic thrombocytopenia purpura. Okay. So idiopathic because it just kind of spontaneously happens, and it's going to be involving the platelets. And this is a reduction of platelets resulting in purpura. Okay, so we'll learn what purpura here is in a second. Um, but what we see is this purpura that you're going to see what it is in a second is also the result of a hypocoagulative state. Right? So if now we can't form blood clots because they don't have enough platelets because they've been destroyed by antibodies, then we're going to have a difficult time blood clotting. So there's an acute form and there's a chronic form. So the acute form is most common in children. Like its name suggests, it's sudden in onset and it's self-limiting, right? So it turns off by itself. Now in this chronic form, we see it's more common in adults in between ages 20 to 50, and unfortunately it's more common in women than it is men. So some causes of it, we have idiopathic, which is unknown. Okay, it's pretty much anything. Autoimmune diseases, immunizations with the lead vaccine, immunodeficiency disorders, and virus infections can all be causes of this idiopathic thrombocytopenia purpura. How's it going to manifest? Well, obviously bleeding. This is the primary indicator. Bruising, formation of petechiae can be any indication of bleeding. Okay. And so actually the purpura is going to be a bigger component. It's pretty much just going to be like a big bleed underneath the skin. So to diagnosis, we're going to do blood count. So we're looking for a reduction in platelets, less than 20,000 cells per milliliter. Remember that the circulating value was 150 to 350 cells per milliliter, so we're getting very, very minimal as far as platelets being around. We're going to perform bleeding studies looking at bleeding time and formation of certain factors. Yeah. And now for acute idiopathic thrombocytopenia purpura, okay, we see the treatment can include glucocorticoids, which again, I hope you remember that this is including the corticosteroids that you go to the doctor and get, right? Mimicking the function of cortisol in our body. Immunoglobulins, right? So those would be like antibodies. Okay? Plasmapheresis would allow you to kind of clear the plasma from any kind of toxins that are antibodies that are causing this. Platelet pheresis. Okay. Now we're cleaning the blood essentially of the damaged platelets, and so we're trying to save as much as we can. Now, chronic ITP, you would get a lot of the same treatment, right? So glucocorticoids, immunoglobulins, splenectomy. So they might end up taking out the spleen in response to this, because we get this platelet destruction resulting in this idiopathic thrombocytopenia purpura, and so that destruction occurs in the platelet cell or in the spleen. And so another option would be blood transfusions, and then immunosuppressant in the case that it is autoimmune in origin. All right, so on this condition, we're going to see it is called thrombotic thrombocytopenia purpura. Okay. And so this condition is going to originate from an enzyme deficiency. The enzyme that is being improperly produced here is responsible for cleaving von Willebrand factor. Remember that the von Willebrand factor was attaching the various platelets. So this condition can actually lead to a hypercoagulability. So now you have an increased risk to form clots in circulation. So this hypercoagulation that occurs, since it's von Willebrand factor is doing such a good job, it's actually decreasing the circulating platelet levels as a result. Okay, so we can look at this cascade here, and so the von Willebrand factor isn't heavily shown, but here's factor 8 that we saw in von Willebrand factor. Okay, so this condition is going to be characterized by the formation of blood clots, thrombosis, okay, thrombocytopenia, which is a decreased number of platelets, and then bleeding, lastly, right? So as they form these blood clots in circulation, okay, then they're going to bleed more because they can't stop bleeding, right? So thrombocytopenia, you get a decrease because you're forming blood clots because of this deficient enzyme that cuts von Willebrand factor. What causes this thrombotic thrombocytopenia purpura? It's idiopathic. Okay. It can be hereditary. So bone marrow transplants can cause this. Cancer, medications, pregnancy, HIV. And so we see a really large number of origins for this disorder. How does it manifest itself? Purpura. Purpura, again, are bigger bleeding spots. And so we get these big bleeding spots, kind of like the petechia, but larger and not as numerous a number. So we can see changes in consciousness. And so anytime you get bleeding, you can get a decrease in blood volume, which would decrease blood pressure. And so if you're not providing enough blood pressure to move the blood to the head, to the brain, then you lose consciousness. We can see that individuals are confused, or they seem tired. Okay? Fever, headache, tachycardia, pallor. Right. So this increased bleeding that has occurred is causing somebody changes in their blood volume, changes in their blood pressure, which are resulting in this pallor, tachycardia. So we have these conditions in which we can look at what is happening to the blood or to the body and make sense out of it. And that's kind of the way we want to do things at all times in this class. So we want to make as much sense out of the manifestations as possible. So you're going to have dyspnea because what you're doing is not really working all that well. Speech change would be associated with the neurological problems. Okay. Weakness because you don't have enough oxygen for ATP because you're bleeding. And then jaundice. Okay, jaundice would be a yellowish tint to the skin due to the breakdown of hemoglobin. So these would all be due to the blood loss underneath the skin. All right, so with that, I want to end this lecture on platelets and the function of platelets. And until next time.